Good afternoon, everyone, to those in Ontario, and good morning to those in the West Coast. Welcome to today's webinar, There's Nothing More Expensive Than a Misdiagnosis. We can all agree that patients cannot achieve the best outcomes when a diagnosis is wrong. Today, we will go through the strategic steps to help you navigate this topic and help you transform your patient outcomes in a positive way. Before we start, I just wanted to provide a few tips for a smooth experience. If you haven't already done so, you can go ahead and download the presentation slides. There's a handout tab on the right side of your window. Download that. We will use the chat for any questions you may have and also for you to interact and participate in today's webinar. You can expand your screen to full view. Just hover your mouse on the top right corner of the window, click on the double arrows and expand it. Today's webinar is being recorded and the replay will be sent out automatically to everyone that registered. For those of you that are here live with us today, we do have a contest entry and it's a chance to win one of 4 digital gift cards. All you have to do is pay attention and enter the 3 secret words that will appear in the chat throughout the webinar. At the end, there's going to be a contest entry page. You'll be redirected where you'll enter those down, and then we'll just pick randomly the 4 winners, and you'll be notified by email. I also wanted to take this opportunity to make sure for those of you in Ontario are aware of our newest tool and upcoming launches, which are happening in the spring, and that is our Smart Requisition tool and the option for patient pay. This is for Ontario only, and MDs were notified by email with just an early notification with what's new, what's coming up, and how you can opt in for patient pay. If anyone has any questions about those 2 things, please contact either myself or Sarah Brody-Brown, my colleague who takes care of GTA West. Without further ado, please welcome Dr. Sarah.
Hello, everyone. Thank you for having me. I am super excited to dive into this topic because I have been ranting on this internally in our clinical rounds calls for honestly, for months now. But one of the things, so Saroma and I always sit down and we look at feedback from my courses, feedback from people I work with, and feedback that she's getting. And one of the things that we really came up with and that I really see as a huge pattern is that we are not taking ourselves, I think, this is my opinion, not Saroma's, as seriously as we need to be when it comes to the type of medicine we can provide. And right now we are in a situation where just this morning, my team on clinical rounds, a patient was given a diagnosis and she doesn't have a medical team that is exploring, understanding, treating that properly. And we're seeing the medical system fragmented more than ever before. We're seeing people really just pulled to the end of their scope of knowledge more than we ever have been before. And so that's resulting in people coming into your office with information that may or may not be completely accurate. And it is our job as practitioners and as doctors doing real medicine, as one of the podcast interviewees I was on last week said. I was interviewed by an REI and he was like, wow, you guys are doing medicine. And I was like, yes, we are. And I think sometimes people hear that and they're almost offended. They're like, of course we're doing medicine, but we are doing medicine and other communities aren't aware of that. But it is our job to take that seriously and to take that on and to be able to support a patient. So I actually have 2 cases today where we got these initial lab sets and had to do a lot of finessing to understand what was actually going on. And so we're going to break that down more than ever before. So we're going to talk about misdiagnosis, and it's important for so many reasons, but I'm going to get into why I think it's costing our profession to a certain degree, its reputation. I think I'll go on a little aside and then I'll come back. But we're really worried about being viewed as a profession that's expensive or unattainable. But I'm really worried about being viewed as a profession that's not effective. And I would rather help a patient understand the value of getting an accurate diagnosis and getting their healthcare journey supported than I would risk not giving them treatment that's efficacious. And there's a lot of people dancing that line right now. I, again, as someone who very fortunate to work with many, many practitioners on a day-to-day basis, I'm having that conversation more now than I think I ever have been before. And one of the conversations I always have, and the things I say right out the gate, is I'm like, did the patient tell you they couldn't afford this, or are you not offering it? And that has to be a critical conversation. Your patient comes in, they may or may not have primary care. They may or may not have a supportive practitioner. They may or may not have a diagnosis. It is our job to do informed consent, to tell them what their best option is. And then it is our job to work with that and to support them through it. But we're doing really crazy things. And I'm just going to go out and say it. We're like, okay, get this test here and go here and do this. And patients are running around. They're exhausted. They're more time poor than financially poor. They are not getting the right treatment. They're emotionally broken down because of that. And it's just, if we don't turn this around, I'm very passionate about this topic, as you guys can tell. If we don't turn this around, then we are going to deal with a whole new set of problems that we didn't think we were going to be dealing with. And that is, again, how the perception of our profession is when it comes to efficacy and doing real medicine and doing our jobs. So total aside, but it's one that I feel extremely strongly about. So anyways, we're going to talk about testing. We're going to talk about just getting into like how to put a patient on the right path. And then we're going to go through some examples. So I think I already covered this, but I diagnosed men too in my practice a couple of weeks ago, right? I'm diagnosing a variety of autoimmune conditions. I am supporting a patient's immunologist on how to prescribe the proper set of immune regulating immunosuppressive pharmaceuticals, right? Like I am working with patients' reproductive immunologists on the stack of pharmaceuticals that they need to work with my supplement plan. We are doing real medicine. And if we don't have lab testing to help bridge the gap in that conversation and bridge the gap in diagnostics and bridge the gap in all of those ways, then we're really missing out. So we'll get into that and more. But first and foremost, there have been studies done on why people see naturopathic doctors, right? And I think it's a very important thing to remember fundamentally why they're seeing us. They felt like conventional medicine didn't solve their problem, right? They wanted an approach because they wanted a different approach because what they're doing isn't working. The current treatment isn't working. They're fearing disease progression. They want to look at the whole picture, right? These are their terms. They're trying to figure out why something is happening. And then they're coming into our office and we're saying, okay, perfect. Go back to your doctor. I'm just going to pause on that for a second because we are having people who come to us struggling with a system, and then we are sending them on their own back there to say, okay, perfect. It didn't work for you last time, but try this time. I have a lot of interaction with the patients of Advanced Women's Health, right? We see thousands of patients a month. And the feedback we get is that they felt like that was a struggle, right? They felt like, I wasn't sure how to get the support I needed because now I have to go back to someone I already doesn't understand me. And so we need to be able to communicate with patients. Yes, they may need to go for diagnostic testing. You may not have a nurse practitioner that you can refer to for imaging, etc. So they may need to go back, but we need to help draw a map for them so that they can understand how and why, right? And they can understand the depths of the support that we can provide them when we get the right information and the right diagnosis. It's well recognized. Yeah, I've got stats on that in terms of misdiagnosis, 100%. It's not just us. Like, I need to be clear, it's not just us, right? And the cases I'm going to go through with you are an example of where it's not just us. It's a case where someone is coming in and they're coming in with a diagnosis, and it is our job to ensure that that's right. It's our job to not trust. And I used to say when I first started, 10 years ago now, which is crazy, I used to say, oh, like all of the big stuff has been ruled out. You probably have heard me say that. You can assume that like the big things, cancer, this, that, the other thing, are ruled out. Now you can't. It's different. We're in a different ball game, and we need to take ourselves to that level in terms of how seriously we're considering it. So then, 32% said they wanted a natural health approach. People are looking for a desire for health optimization, prevention. They want more data. There are lab testing companies right now in the US that are skyrocketing in terms of their valuations. And it is because they're offering extremely comprehensive panels, and their whole claim to fame is we don't miss anything. Patients are spending thousands of dollars to do these tests. There's a huge appetite for them. God knows I get sent them all the time. And a lot of the tests they're doing, I wouldn't do them in the methodology they're doing. And then patients are bringing us the results, and it just gives you the interpretation. And I'm like, we can't do anything with that, but we could have run those tests in the first place. So you have to ask your patient, right? So then when we look, again, it is diagnostic error is a huge issue in the US, right? 5% of outpatients, that's a minimum. And then we're looking at 1 in 5 is leading to patient harm, right? 12 million people minimum a year are experiencing issues with diagnostic error. And it is resulting in delayed treatment, right? People are not getting a treatment. They are getting a progression of their conditions. They're getting treatments that are expensive and unnecessary, right? If you recommend based on a diagnosis, someone takes home, let's say 5 supplements, and they have to take those for 3 months, that's hundreds of dollars that we could have used to get the right diagnosis. But the thing that gets me the most, and then I promise I will transition out of this attitude about it, I have patients that have seen multiple doctors, let's say, I would say on average, somewhere between 5 and 10. And they come to me, they wait for years, sometimes, to see me. And then they look me in the eye and they say, I know I'm here, but I don't know if I'm actually capable of getting better because no one else has been able to help me. And when I look, there was assumption after assumption after assumption after assumption that the last doctor was right. And that psychological distress is, I think, the undertones of why people are coming to us, because they want us to look at everything. They want us to put it together. They want us to put a plan together for them and say, you've got this. We can do this. And we are the integrators of the healthcare system. And I think when we take that role really seriously, that's, I think, why I'm honestly good at my job, is because I was, to this day, skeptical all the time. And I was like, this is what we need to do to prove if I'm right or I'm wrong. And people are very happy to do that. So most common misdiagnoses, this is just a short list of things that I would say we see on at least a weekly basis. People being diagnosed with IBS, pelvic pain, chronic UTIs, interstitial cystitis when they have endo. People being diagnosed with unexplained infertility, HA, PCOS or adrenal PCOS. We see people experiencing weight gain and they're told, oh yeah, you're not getting pregnant because you're overweight. When it's like, okay, that could be a bigger piece here, right? Then we look and we see celiac disease, right? So IBS, iron deficiencies, that's coming up. We see autoimmune thyroid conditions, misdiagnosed, anxiety, depression, postpartum. You see that in a big way. Again, lots of POTS, dysautonomia coming in with fatigue, panic, anxiety. And this is just what I'm seeing. You guys are probably seeing a whole scope. Actually, I would love to know, what are you guys seeing as misdiagnoses? Throw that in the chat because we're all seeing it. So I would love to know some of the common things that you guys are seeing. Again, insomnia, fatigue, headaches, sleep apnea, perimenopause coming in as a whole list of things, and then andropause, metabolic syndrome, depression, kind of all being intermixed. So yeah, I'll let you guys throw that in the chat as I continue on because we got lots to cover. So lab sets for adequate diagnoses. Many of you guys know, and I've done webinars on this in the past. I'm sure Saroma and I will do more in the future. And if you're interested, let Saroma know. This is how we choose these things. But I believe there's 5 to 7 causes of disease. That's it. That's all. And so if that's true, then we need a lab set for those 5 to 7, and then we can make the most accurate diagnosis for the patient in front of us. And so this is how I categorize things when I'm trying to understand what's going on with the patient. Do I think it's hormonal, inflammatory, deficiency state, gastrointestinal, right? Metabolic. And so these are the different systems or patterns or categories that I'm looking at when I'm trying to say, this is my wide net here, and what am I casting? What am I trying to understand? So, any questions about that before we get into the cases? And for reference ranges on that, for more information, again, we have previous webinars. Saroma always includes them because she's so organized and keeps everything all in a little beautiful little container. So she'll send that out afterwards. If you're a newer practitioner, you can get your hands on all of that. And like I said, I'm sure we will do some more information on those coming up. Okay, no questions. Let's dive in. So, this patient came in, she was 31 years old. She came in with an irregular period, absent depression, fatigue. So her irregular period started in her late teens. She was a gymnast in high school. She failed the progestin challenge. Her diagnosis was hypothalamic amenorrhea, and she began the oral contraceptive pill. The oral contraceptive pill impacted her mood and libido, as it does. And so she came off it when she was 22 and had an IUD inserted. Her mood didn't stabilize. She became more irritable. She felt like she was having cyclical PMS while on the IUD, more anxiety during that time. Sleep quality was poor. She took Wellbutrin, and she said it took the edge off. She'd also tried a variety of SSRIs and other medications. And then her IUD was removed at 29, and cycles were still irregular. Went to see her family doctor for progestin challenge and labs. They agreed to both. She bled with the challenge, but still irregularly. Labs presented below are, so on the next slide we'll go through. She had a BMI of 22 on the initial visit, and she had seen 3 NDs in the past. They had given her things like Vitex, seed cycling, omega-3s, many custom hormonal tinctures, a higher fat and higher protein diet, an elimination diet, inositol. She had done progesterone cyclically. She had done many adrenal formulas, mitochondrial formulas, and a hormone detox. Her goals were to conceive in the next 6 to 12 months, improve her energy and sleep, and to reduce depression and overwhelm and PMS. So these were the MD labs. So this is what I have on first visit. Okay. So we've got white blood cell count low, right? 3.7. We've got her RBCs also on the low end, hemoglobin on the low end, would like to see that closer to 140. Her MCV was okay. Platelet count, a little bit low, but honestly fine. Her neutrophils and lymphocytes were both, again, low. Neutrophils quite low. We see that overall her HbA1c was 5.2, which was okay. And then we had her TSH at 1.6. They did a 17-OHP. It was fine. DHEAS was 5.6, which was good. FSH was 5.7. LH was, and this was down follicular. LH was 2.8. Prolactin was 6.5. Creatinine, I always do that, was 62. EGFR normal, and ALT was 18. So what are our DDXs for this patient? What do we got here? Throw it in the chat. What are your DDXs? What are you thinking? We've got a bit of a delay, so I'll sit here awkwardly for a second while you guys throw your DDXs in. No free rides on a Monday. Adrenal burnout. Okay, great. What else do we got? Suspicious for PCOS, okay. If anyone wants to take a stab at what labs they would run too, that would be fun. Let's do that. or if you need any follow-up labs. B12 deficiency, vitamin D deficiency, okay, adenomyosis. Vitamin D. It's funny that, Chris, you say that because adeno is like on the rise right now. I just recorded a whole lecture on it because we're seeing a lot more of it. Something's still going on with the thyroid, Hashimoto's, yeah. Would run an insulin and fasting insulin lipid panel, great. Androgens would be nice to know. Yeah, we just have DHEAS and 17-OHP, so yeah. Any other DDXs? Vitamin D, full iron panel, thyroid antibodies, glucose challenge, great. Anyone else have any DDXs for me? Okay, prolactinoma. Yeah, her prolactin was 6.5, but yeah. Premature ovarian insufficiency. Okay, let's do it. So, this is what I ran. So keep in mind, I actually, because of the results we got, I had to send her to the lab a couple of times. So something autoimmune. Okay. So that's why it looks a little bit garbled, but let's do it. So her white blood cell count came back up a little bit. Her neutrophils were still low. We see her RBCs nominally increased from what her MD had done, but overall very similar white blood cell count. We see I did run, again, a full thyroid. So did antibodies, did T4, T3. Her T4, I would like to see 15, 14 to 4.4. So we want to see it right around 4.5. So that was good. Then we run this. So again, there's a couple different pieces here. I need to understand what is happening, not just at one cycle, but multiple cycles. So why could we be in a situation right now where her FSH was 55.3, her LH was 23.9, and the last labs her MD did were like 5 and 2 or 5 and 3, right? Her prolactin's also low. I ran a CA-125 because I was just trying to, again, understand if there was any ominous processes here. That was normal. But why? What is the difference here? What are your thoughts? Follicular versus luteal, great question. Nope. So this is follicular as well. So this was also a follicular. You wouldn't see this much of a jump in FSH and LH with luteal. Just in case you ever do see it, you wouldn't see this. Anyone else have thoughts? One ovary has pathology. She's 31 years old. Yeah. Her MD didn't test her estrogen. So when we look, her estradiol here was 119. And her progesterone, so this was, again, this is a woman who is cycling all over the place. So her progesterone in this situation was at 31. But we thought she was follicular. So these things happen all the time with someone who's what we call offloading follicles. There's just this really erratic bleeding patterns. There's really erratic cycles that are happening. But estradiol suppresses FSH. So if her MD ran those labs when her estradiol was 2000, right? When it was 1800, which happens all the time with follicle offloading, all the time, whether that's premature or in perimenopause, then that's going to suppress the FSH and the LH. And so now we're in a cycle where her estradiol has come down, her progesterone's up a little bit, but we see the true FSH LH. Yeah, luteal etaphase, exactly. That's the name of the cycle. So I sent her to a fertility clinic because fertility was her goal. And I was like, I don't know if this is new onset. I'm assuming it's not, because this HA-like pattern could have been perimenopause onsetting when you're in your early 20s. So I sent her and I said, you know what, but we got to shoot your shot. So she went, they followed up with this testing. And again, we see here her FSH, LH, like things are still high. So now we have repetitive testing to show us that. Okay. I did her insulin glucose challenge test, of course, because I always do. And we see some significant insulin resistance here. So her fasting insulin was 138, should be less than 50. Her fasting insulin was 660, or sorry, her half an hour was 660, went up to 609, or no, down to 609, sorry guys. And then up, my brain's working too fast today. And then up to 681. We see her glucose is reasonably controlled here, but she's making way too much insulin to control that. And then we see at that 2-hour mark, both of them jump. So a little stress response there, something going on that caused that glucose to go up, but then also caused the insulin to chase it. So this is a stress sensitive, insulin resistant type pattern. And like I said, these are the labs that I was like, okay, we need to put this puzzle together. So her ESR was at 3, her ferritin was at 55, ANA was negative. So to those of you who commented autoimmune, I was like, we need to check that. CRP was fine. And then I ran her testosterone and DHEA. Both of them were also like, they are low for her age category, but not for her ovarian status. So what that's telling me is that this patient is, again, she has POI. So she has premature ovarian insufficiency. She is in the later stages of perimenopause, if we were staging it, but she still has an intact androgen status. Okay. We see then her cholesterol. So similar to her insulin, there's some metabolic dysfunction here. We see that her cholesterol is, or triglycerides are at 1.56. We want it less than 0.7, 0.8. Her cholesterol is sitting high at 6.16. Her HDL is 1.09, so that's low, which happens with high triglycerides, happens with insulin resistance, and happens with our perimenopause patients, right? Because we're in this situation where that estrogen is so important for proper signaling of insulin and proper disposal of LDL and all of these different pathways. So this patient, we now have to control her metabolic risks. Do you prefer testing free testosterone to total? I do, just because a lot of my patients do have issues with sex hormone binding globulin. So that just kind of removes that as a factor. There's just lots of liver dysfunction and SHBG function. Yes. So the difference is that her MD, as we typically see, did not run her estradiol. So the question was, what was the difference with her FSH going from 5 to 55, right? And her LH going from 2.9 to whatever it was, 23, I think. But the difference is that we didn't have estradiol. So all of those other 3 NDs saw her labs and they were like, her FSH, her LH is fine. But if she was in a situation, which she must have been, where her estradiol was very high, estradiol suppresses FSH and LH. That's how the birth control pill works, right? It's the feedback loop. So if you only test one side of a feedback loop, then you're going to get a misdiagnosis. And so we need to be testing that at the same time. Yeah, exactly. Perfect. So her diagnosis of HA has now been overturned. Her diagnosis is premature ovarian insufficiency. And she needs to be treated immediately. She needs to get proper levels of estradiol and proper levels of progesterone. The research has shown that this patient category that do not get proper estradiol and proper progesterone support, normally in the form of oral hormones, their risk of everything is so high. Dementia, Alzheimer's, their risk of cardiovascular disease, their risk of, again, when we look at bone health, all of these things, right? All of these things are so foundational when we're looking at understanding the right diagnosis. This patient was then also not able to proceed with fertility treatments. There was nothing left. And this piece, to me, we're seeing a lot right now. Like, we're seeing a lot. There is more premature ovarian insufficiency now than before when I started practice. Pre-pandemic, the only cause of POI that I ever saw in my practice was iatrogenic or was related to thyroid antibodies. Post, we see a huge change in causes. And if this had been caught in the 5-6 years she was seeing other NDs, And I didn't say this because I never want to break anyone's heart, but you guys need to hear it because you're the doctor. We could have potentially had a different diagnosis, a different outcome for this person, right? She may have been in a position where they could have gotten some embryos. Eggs, probably not. Now, she wasn't partnered at that time. I can't remember her timeline, but she might have had to use donor sperm, but she would have had choices. But unfortunately, because we saw a diagnosis of HA, because FSH, LH, estradiol were not tested at the same time, because the labs that we had seen were not too bad. This patient went undiagnosed. She's already had, because she was on an IUD, so she's already not probably had enough support. So she, again, was immediately referred because I can't do oral estradiol or progesterone. Plus, she needed a DEXA because we needed to understand the magnitude of osteoporosis and osteopenia, where she is. She's only 31, but she could have been that whole time on that IUD not ovulating, or not ovulating enough that we had enough hormone to protect her brain and her bones and her cardiovascular system. So this is what I mean, like real freaking medicine here, everyone. We are in a situation where we need to be doing this. So we referred out the POI HRT dosing, resolved her mood and sleep concerns. We also then, again, see improved cholesterol panel with weightlifting and a low food insulin demand plan. And now she's on annual maintenance and dose adjustments. But I just, again, want to reinforce, if anyone would not have gotten that diagnosis, which only one person had that on their DDX list, now's your moment. Like, I want to spend the next 5 to 10 minutes for you guys to ask me questions that will help you get this diagnosis in the future. Because again, awareness is one thing. So now you have the awareness, but what about all the other misdiagnoses? So I want you to think for a hot second, right? And go through, how did I miss that? And is there a question I could ask Sarah to ensure that I don't miss that again in the future? Okay. And then,
hi, Dr. Sarah. There's a few on there. So while we're waiting for new questions that you just asked, if you can take a look at some of the interested questions already in there.
Okay, there was a question that came in privately that was just about testing free testosterone. Why wouldn't you want to test total and sex hormone binding globulin or like bioavailable? You absolutely can. Like you can test total and sex hormone binding globulin and free. I found free, honestly, doesn't lead me astray in practice very often. So that's probably just more an experience and time thing than anything else. But that tends to be the one I test the most. Okay. ICMDs order 17-OHP instead of progesterone for patients who wanted to explore hormones. What am I missing via ordering this versus progesterone? God only knows. So progesterone, you know what? I'll sit there for a second in that kind of MD lens. Progesterone is a test for ovulation. That's it. And so if you have an anovulatory patient, they're thinking about why they're anovulatory, not if they've ovulated. So my best guess would be 17-OHP is your NCASH, right? So non-congenital adrenal hyperplasia. So in that, if we're testing for that and that's high, then that would prevent ovulation. And that's something they can treat. MDs don't treat the diagnostic, like functional ranges of progesterone. Is it over 13 to 16 that you've ovulated? Otherwise, they don't care. So I think it's probably just diagnostics is going to be my guess, although I'm not in their heads, but let me know if that makes sense, because that's my best guess. Okay, did I miss one there? Would love to hear how you tell patients that they need to do repeat and more comprehensive testing when they're hesitant to pay out of pocket. Ooh, I love this one. So this is an example, right, where I have a patient come in, they're given a diagnosis. I need to do more work. And so they're going back to the lab. In any situation, when I talk to a patient, I always say to them, we need to do an initial set of diagnostics. Okay. You're then going to go on treatment. After about 3 to 4 months, we're going to need to repeat testing because unfortunately, I can't just like read your body like a magician, right? And be like, oh, things have improved. Your symptoms could have improved, which is great. But if I don't actually treat what the labs tell me your risk factors are, then you could have improved this 50%. But if we stop treatment, then you're going to lose all the traction you just got really quickly. Whereas if we retest at 3 months and I treat the last remaining pieces, then you could potentially have long-term results. So I think part of it is like the confidence of knowing as a doctor, you need these things. The other part of it is knowing how to treat the results of it. And then the last piece of it is, and I hear this from docs all the time. So if you're in this category, you're not alone. They're like, I'm worried about retesting because what if it's not better? And I'm like, okay, fine. But you can't worry about seeing something you don't know how to treat or seeing data and that be the patient's experience. Yeah? Saroma, can you hear me?
Yes, sorry, you cut out there for like a little second and then your video froze, but we could still hear you. It cut
Okay.
out just for a few seconds, but I think we got pretty much what you were saying. You can carry on.
Okay, thanks. So my team will come to me and they're like, we have a problem. And I'm like, okay. And they're like, it's really expensive to solve. I'm like, okay, preparing myself, right? And they're like, it's $500. And I run multiple clinics. A really expensive problem in my mind, I was like, they're coming at me with like 10K. It's a very, if your patient says, oh, that's expensive, you need to just sit down and say, what is your budget for this then? You can't just extrapolate that you know what that means. Because I have patients that say that all the time. Oh, so and so this thing is expensive. And I'm like, okay, cool. What does that mean? Like what can I spend? What can I work with? How are we going to outline this? And oftentimes they're like, I had my friend spent like $2,000 or $3,000. I'm like, cool. How's like 250? They're like, yeah, no problem. So you may be happening in your patient's brains. So I find patients are more than fine when you can explain to them what's going on. You know why, right? They understand why they're doing the testing. And then you work with them on a budget, right? But that's, you have to go back and forth. You can't just be like, here's a list of testing, run away, right? And we also can't assume they don't want anything. So that's my thoughts on that. Okay. I think that was questions. I got those ones. What's your opinion on testing hormones via serum, saliva, or urine? Honestly, I think all of them have a lot of value. It just depends. Like in this situation, I'm doing diagnostics, so I want serum testing. If you are looking for output of hormones or patterns over time, urinary hormones, I don't even do as much of the dried urine anymore. I do like the at-home urinary hormone tests a lot. But if you're looking for something over time, that can be helpful, but that's not diagnostic. So oftentimes when you're doing salivary hormone testing, you're doing dried urine testing or any kind of urine testing, you're matching that with a couple key points in serum. So they're all telling us something useful. It's just you need to know what they're telling you, how you're eliminating hormones. So for example, I have a genetic variant in how I glucuronidate hormones. And so I actually don't break down estrogen in my urine very well. So I never see the full extent of urinary elimination through glucuronidation. So through P3 or through any of glucuronidation, but my sulfation pathway is increased. So you can understand a lot of different things. I have seen the REMS ultrasound test as an alternative to DEXA. I honestly haven't used it, so I can't say I know too much about it. Okay, great. Can you elaborate on why you're seeing post-pandemic POI? Yes. there's a lot of things that are going into it. How do I tackle this? I'll do this quickly, and then by all means, I have lots more information on this. There's a few different things, but there's inflammatory response changes that happen post-pandemic. There's circulatory changes that have happened. There's fibrosis in the ovary changes that have happened. And then there's anti-ovarian antibodies that we're seeing increase in the research. So the research is clear, it's increased, and it's generally one of those mechanisms. But yeah, it's a big conversation. So low neutrophils is something we're seeing a lot right now. Many of you guys are probably seeing it. The virus that went around in the fall, the really weird cyclical one, was having a big neutrophil impact, and it's taking upwards of 6 months to see that resolve. I'm getting weird internet alerts. Hopefully you guys can hear me okay. If you can't, Saroma, I'm not going to keep asking. If you can't, just let me know. But
yeah, it's okay, Dr. Sarah. It's just your video. It keeps coming in and out, but it's doing it automatically if your internet's just a little bit low bandwidth, but we can still hear you. So
okay,
we're good. And I think you answered the neutrophil question. Did you answer Christopher Brown's question about 17-hydroxyprogesterone is for PCOS or other androgen conditions?
It is for you can use it in PCOS, but it's for non-congenital adrenal hyperplasia. But I'm deleting the one. Yeah. So we don't lose track. Okay, great. No, phenomenal. Thank you so much. And then to cap off the neutrophil piece, so we're seeing a lot of that right now, but then also we are seeing like certain immunological patterns, especially post-viral patterns, can have low neutrophils. So that's one of them. Okay, at what level of estradiol do you start to worry the most, especially if they don't know the phase of the cycle, because it's so irregular? So if you're testing FSH, LH, estradiol, and progesterone, I don't actually need to know where they are in their cycle. I can guess. If progesterone's low, estradiol's low, FSH and LH are low, then you're either luteal or you're not ovulating, right? And so if you have all four of those, people always say, oh, I am so sorry, I don't know where I was in my cycle. I'm like, I can figure it out. I can't know exact cycle day, but I can figure it out, right? If you see LH is high, FSH is like a little bit up, estradiol's really high, progesterone's low, that's ovulatory. So you can really get a solid understanding of where someone is. But if someone's estradiol is like less than 80, I'm asking questions. Less than 40, of course, but like less than 80, especially if we don't know what's going on, I'm asking questions. Okay, I'm going to do the stool testing one at the end if I have time. So I may be misinterpreting the estradiol aspect of this case. Realistically, with her fluctuating FSH, would it be the case that she is likewise would be showing normal estradiol, or if they had checked her estradiol fluctuating high and possibly low? Yeah, so her estradiol is going to be doing this, because what happens is as FSH screams at the ovaries, there's not many follicles left. But then all of a sudden, when the signal gets loud enough or it overcomes the resistance, boom, you see this offload of estradiol. So you can go into thousands, and then everything FSH, LH suppress, and then things go back up again. Dance. Okay. I think I answered most of these. Okay, perfect. So let's get into the next one. So this patient here is a 43-year-old female diagnosed with Graves, not tolerating medications. So she has anxiety, constipation, and diarrhea. Fatigue at the end of the day, not improved with prescriptions, glasses. She was diagnosed with Graves, and she was given a treatment for that, so methimazole, 2.5 to 5 milligrams, and felt significantly worse. She saw one ND shortly after. She was given right? So Lycopus linearis, that one. And then she was told that she would not likely feel better until she had RAI, so radioactive iodine or removal. These were the labs that she came in with. So again, we see white blood cells on the low end, red blood cells low. We see her hemoglobin was low, so just lots of deficiency states here. Again, white blood cell count across the board was low. Her erythrocytes or sedimentation rate was 2. So this is where it gets fun. Her TSH was 0.9, and then repeated, it was less than 0.1. And then 14 days later, it was 0.06. So they repeated it multiple times, was suppressed. Her estradiol, they did because she was having a whole bunch of, again, just very abnormal symptoms. So she got sent to an endocrinologist. So they did a progesterone was 0.9. So she hadn't ovulated. They did an estradiol at 105. They did her parathyroid, which was normal. Her ACTH was a bit low. They did her aldosterone upright. So that was on the high end. Her renin upright was 22.7. DHEA was 6.2. Her cortisol was 480. So that was normal. So then I did my labs because I was like, I need to know what is going on here. Because again, when someone is feeling that unwell, like really just not okay, you have to start asking, like, why is she not tolerating medication? So we see here, her TSH is 0.25. Her T4 was 10. Her T3 was 2.5. Her reverse T3 was 12. Then again, reran again, because this is the moral of the story, is we keep sending patients back to the lab sometimes. We had another TSH that was suppressed, a T4 that was 10, a T3 that was 3.1. We see her anti-TPO and anti-TG negative, and her TRAB, so thyroid receptor antibody, was less than 1. So her MD and her endocrinologist refused to run TSII or TRAB, the antibody for Graves. They wouldn't run thyroid antibodies. And they also would not run T4 and T3. And so she had one T4 in her whole history. Now, is that wrong? Yes. Should this patient have been given that? Absolutely. But this is the reality of what's coming into our office. So when you look at this, what are you guys thinking? Right? Because we have a patient, reminder, she was told she has Graves' disease, right? She's losing weight. She's anxious. She has insomnia, constipation, diarrhea, visual changes, right? She was told she's never going to get better. We have low white blood cell count, low red blood cell count, low inflammation overall, and then this wacky thyroid pattern, right? And so what are we starting to think here? I'll let you guys put that in the chat. We have, again, her white blood cell count was sitting low. And this is very common with these like post-viral issues that we're seeing right now. Neutrophils were very low. Her iron was 34. Her transferrin was good. B12 was lower than I'd like to see it. HbA1c is sitting at 5.3. Thyroid storm, yeah. What else do we got? Celiac. Was it viral thyroiditis and now she's over-medicated? What else? These are weird labs, right? Like these are the things that we are seeing coming in. And right now, yeah, parathyroid was tested. It was normal. It was 2.8. But we're seeing people come in with these diagnoses. The reason I chose these two is because this is really common right now. This whole like Graves diagnosis when it's not Graves is happening all the time. All the time. Anyone else? What are our thoughts? My slide deck just failed. I don't know why. Sorry, guys. I appreciate your patience with me on this one. Yeah. Okay. My slide 26 wouldn't load, but my slide 27 is loading just fine. So here on her methimazole, pituitary tumor. Yeah. What else? Keep going. Like, this is not an easy case. This is why I bring it up, right? Here we can see on medication. So someone said, and now she's over medicated. So on the methimazole, her T4 was 7 and her T3 was less than 2.3. Couldn't even be identified. TSH was 2.26. You see her ALP was low. And again, otherwise liver panel, because they had done the 9, but otherwise it looked normal. So this is post-viral thyroiditis with pituitary dysfunction, right? So these are patients coming in. They have inflamed brains. We're seeing more migraines. We're seeing more, again, pituitary challenges right now. Research has shown, and if anyone hasn't seen it, so research has shown that when someone gets viruses, and specifically these kind of post-viral issues that are showing up, we can see that their brain has the same amount of inflammation as someone who's been involved in a car crash at high speed. Let that sink in. Someone has a virus and their brain has the same amount of inflammation as a TBI in a high-speed car crash. If that doesn't hit, I don't know what does. So we're seeing this pituitary dysfunction. There was no gross anatomical issues, but we needed to check. We're seeing oxidative stress and damage. And what I always say is when someone has that low hormones, it's like their body, they're driving down the 401, or if you're in BC, whatever, the 99, going fast around corners, and they have no fuel. Their fuel light comes off and they know they can't get off the road. They still have to live. They get anxiety. They get overwhelmed, right? We start to activate norepinephrine and epinephrine pathways, which result in weight loss and appetite change, right? We start to get suppression of our white blood cells, and we just don't have enough. And so we need to be able to support our patients in this way, but we also need to be able to give them a diagnosis that they deserve. So as opposed to being like, you need your thyroid removed, we need to give this patient thyroid medication. We need to lower her cortisol. We need to support her norepinephrine and epinephrine throughout the day. And then we need to ensure she has enough protein for that metabolic function to kick back into gear. So questions about that one, because again, I know people look at this and they're like, oh yeah, you get a whole bunch of weird cases. We see misdiagnosed graves weekly at this point. Like, these are not, yes, they have cool presentations, which is, we like to bring a zebra, right? But this is not abnormal. This is what we're seeing. And so we need to be able to know how to test and support our patients through it. So what questions do we have about this case? And then I can do questions in general. How did she respond to the new treatment plan? Great question. So with the cordyline and the relaxed matrix, she very quickly noticed her anxiety came down. She relaxed. She was able to focus. It was the synthroid and the cytomel. Her vision improved significantly, like right away. She was able to, she didn't realize how much brain fog she had. And this is a patient that, like, sitting in the visit with her, I was like, she is not well. Like, she couldn't focus. But it wasn't like she was sick. You know, when you sit and you can just tell, it's like the words do not compute. But she was a very intelligent girl. She like, everything was notes. Everything was like spreadsheets, because no one could figure out what was going on. And so she was able to quite quickly recover that cognitive function with the synthroid and the cytomel, the visual changes. And then her appetite improved. So she was able to focus on improved eating, but then she was able to sleep and reduce her anxiety and everything with the cordyline and the Relax Max. Relax Max is by a company called Zymogen. And it's inositol and GABA and theanine and like that kind of stuff. But they have a cherry one. It like tastes like juice. It's so good. So good. So yeah, she did. Yeah. So for some reason, slide 26 still isn't loading, but she did see them for the dexamethasone suppression test. And the cytomel. So essentially what happened in this case, now that you asked, Tiffany, is that I wrote a very thorough letter about appropriate diagnostics to her medical team. And I said, this is the medication you gave. This is what I'm tracking. I showed all the labs over time. And I said, TRAB is negative. This is not a diagnosis of Graves. She has suppression of her TSH, but she has low T3 and T4. Here's what happens when you give her methimazole. No one's tested this. No one's followed up. This is bad medicine. The patient went in angry, right? And so everyone was like, okay. So I wrote a suggested treatment plan. And so I was like, we need to make sure that we know what's going on, again, from like the dexamethasone suppression. So at that point, they were happy to write whatever. But then we also we're in a situation that they wrote the script for the Synthroid and the Cytomel. So, but I will, like, if I see things like that, that's just almost like gross negligence, I will write a letter back. And I'm like, here's what you need to do to be better next time. And honestly, like, but again, so even a couple of weeks ago, I had a patient come in and I was like, you look different. And no one had palpated her abdomen, and she had this huge mass in her abdomen. And I wrote a letter to her doctor because her doctor had said it wasn't urgent. I'll get you in a few months. Wrote a letter to her doctor. She was in the next day. Doctor copied me on all her ultrasound reports, her surgical report, because she had to go in for surgery like 3 weeks later because it was growing so rapidly, like all these things. And so they were just like, whoa, okay. But if I see it, I will absolutely call it out, because doctors got into medicine for the same reason we did, to do our jobs. Just like I'm coming on here telling you guys, here's how to do your job better. I do it with them. And some of them don't like it, and that's totally fine. It's not my job to be liked. It's my job to get that patient that diagnosis. Same with, it's not my job for that patient to like me when I tell them the plan and the cost. They're saying, how can I get better? And I'm like, here's how you get better. And if they don't want it, they don't want it. If the doctor doesn't want to talk to me, that's fine. But it's not my job to care what the patient's doctor thinks. It's my job to tell them what diagnosis was made. So yeah, great question. Okay, so before we get into that, of course, Life Labs has been so generous to sponsor our treatment room. So if you want to hear more about complex cases, you guys can get 30 days for free with that link. This is where I interview 4 guests on the podcast, one every week. It's the same case for 4 weeks in a row. And then you hear about how people treat differently. And it's honestly been one of the most fun things I've done in a really long time. So I definitely recommend you guys check that out. We've got a thyroid case in there too. That's interesting. And then, yeah, we're cover digestive health, endo, all kinds of stuff. So definitely make sure you check that out. And then now I will jump into the QA. Okay. What is your opinion on the stool antigen H. pylori versus serum? Do you like stool testing for the diagnosis of active infection in patients who have not had a previous infection? So it's a really, really good question, because I can't remember if it was my team or on one of my mentorship calls with practitioners last week. We were talking about that, how it's so common right now that they are moving towards this stool antigen test. So breath test is gold standard for H. pylori still, even if we're not doing it. Then from there, we have the antibody test. And then we have the stool antigen test. So H. pylori is a commensal. Okay. So what that means is that everyone has H. pylori. When your immune system is not suppressing it, or you don't have enough good bugs to take care of the problem, then that's when we see that it comes up. So H. pylori in the stool, if it's very high, there's H. pylori that's high in the system. But if that person's constipated, if that person has motility issues, it's not perfect, right? Now, antibody testing is also not perfect, because I don't think any of them are perfect. I don't think any of them are phenomenal outside of when we look at the urea, like the breath test, but it is what we're using, right? Yes, and we can send out the link afterwards too. Saroma can help me send out the link, but I think I can find it here. Yep.
Great. Sorry. And you got, Dr. Sarah, did you grab all the questions that were left in the chat as well? Did we kind of
I did, yeah.
Perfect. Okay, good. Oh, let me just see. Perfect. Amazing. Thank you, everyone, for attending today's webinar. We are going to send out the replay at some point later on. If I can get it out this week, I will. Otherwise, it'll be early next week. I will definitely include links to the replays for some of the foundational webinars that Dr. Sarah spoke about. And please do reach out to Sarah Brody-Brown or myself or your reps in the West if you other provinces are attending here. If you have any questions about the upcoming tools, various things happening with Life Labs, please ask us rather than Dr. Sarah. And you can definitely, yes, and we do want to hear your feedback about next talk. So there is a survey that you're all going to get sent as well. Please do take the time. We do actually read those surveys when it comes to coming up with our subjects for the next webinars, because we want to know what you need help with. So those are really important. So please do take the few minutes to fill that out. And if you just wait for this to fully close, you'll be redirected to the contest entry page. So just note down those 3 secret words and then put them into that page and submit it. And then we'll pick the winners and they will be included in the email out with the replay. Let me just make sure there aren't any last minute questions. Perfect. I think we are all good. Thank you so much, everyone. Have an amazing rest of your day. Bye.
Thanks, everyone.